Thank you very much for this opportunity to present a topic of great interest to me. I am a pediatric ophthalmologist and an ocular oncologist at Phoenix Children's, and hopefully I'll provide some clinical pearls on ocular oncology for the pediatric ophthalmologist. I don't have any financial interests associated with the talk. So we'll just go with rapid pictures and clinical pearls. This, as you can see, this is a child with some pigment in the sclera. This is actually nevus of aorta. It is usually associated with pigment in the eyelid. It's associated with pigment in the conjunctiva. The ipsilateral iris is usually more pigmented than the other eye, and there can be some pigment increase in the fundus of the same eye. Incidence of melanoma is 1 in 400, and oftentimes it can be a multifocal melanoma. But more commonly, you can see glaucoma. So hence, it's advisable that you do gonioscopy in these kids at least once a year. And if you do see evidence of glaucoma, it's usually treated very similar to pigmentary glaucoma. It can sometimes also be associated with pigmentation of the ipsilateral palate and the meninges on the same side. So that's why I always advise that all nevus of aorta kids, I do look into their mouth to see if I see a pigment in their palate and see if there's any change in that palatal pigment. Routine MRIs is usually not advised, but I will usually, if a child has some neurological symptoms, then you can get an MRI, because very, very rarely you can have a melanoma that arises in the meninges, and again on the ipsilateral side. Going to our next condition, this is something we all see very commonly in our pediatric practice. It's a limbal dermoid. In this kid, it is associated with a golden heart syndrome, which is associated with preauricular appendages, oral fistulas, microtia, maxillary or mandibular hypoplasia, vertebral anomalies, and in the eye, you can have an eyelid coloboma and Duane syndrome. I usually do not try to excise them unless it's causing significant vision problems, either by obscuration or by causing significant astigmatism, because sometimes the surgical scar produces more astigmatism than what the original lesion was causing. So I try to observe as much as I can. Coming on to pigmented conjunctival lesions, this is a child that presented with a pigmented lesion. Now, whenever you see pigmented lesions in the conjunctiva, there are 4 main things that we think about. One is complexion-associated melanosis, previously called as racial melanosis. Second is primary acquired melanosis. Third is conjunctival nevus, and then conjunctival melanoma. Fortunately, in kids, almost majority of conjunctival nevi are benign, and even when they are excised pathologically, they show benign features. So it's very rare for conjunctival pigmented tumors to be malignant, but still it's good to keep an eye on them. The first picture that you see on the top here is complexion-associated melanosis. It's usually associated with a darker skin complexion. It's usually a bilateral condition where you see diffuse scattered pigments all over the limbal conjunctiva. The picture on the side is primary acquired melanosis. Again, this need not necessarily be perilimbal. It's a scattered pigment, and it's kind of just blotchy pigment that can be in just one quadrant, or it can be a little more diffuse. But if you look at the contralateral eye, you would usually not see the pigment that you see in complexion-associated melanosis. The picture that was seen in the earlier slide, this one is a characteristic conjunctival nevus. And if you see carefully, you can actually see cysts in the lesion, which are very easily seen in the slit lamp. So once you see that, you know that you're likely dealing with an nevi. And of course, this picture here is a picture of a melanoma. Now, as a general dictum, whenever you see pigmented lesion in the fornix, tarsus, or the cornea, it's likely pre-malignant or malignant, and it should be excised. Coming on to this picture, you see a little bit of an anisocoria. The right pupil is larger than the left pupil. And then when you look at the child in light and dark, the anisocoria is accentuated by dim light. So this is a Horner syndrome. Whenever you have a child with Horner syndrome, you have to do a cross-sectional imaging of the brain, neck, and thorax And it's also a good idea to get urinary catecholamines to rule out neuroblastoma. The other thing you can do in your clinic is do an apraclonidine test, where what you do is you baseline measure the pupils, you add apraclonidine to both eyes and re-measure the pupils in the same lighting after 30 to 45 minutes. And you'll see a reversal of the anisocoria, and you'll also often see a reversal of ptosis if it was there in the beginning. And this happens because the adrenergic receptor supersensitivity in Horner syndrome. This is a very useful test because as it is, you see a lot of physiological anisocoria in the clinic, because 20% of kids are supposed to have physiological anisocoria. So it's good to do this apraclonidine test sometimes when you're not sure if it's a physiological anisocoria or is it Horner syndrome. Coming on to tumors. This is a tumor that you see in the ciliary body region. And as you might have already guessed, this is a medulloepithelioma. It originates from the non-pigmented epithelium of the ciliary body. It usually occurs in the first decade of life. So it's usually more common between 5 to 10 years of age. So it's not the retinoblastoma age group, it's slightly older kids. Metastasis is very rare with medulloepithelioma, but often you see local invasiveness. Most medulloepitheliomas occur in the ciliary body, but rarely you can also see it arising from the optic nerve. Traditionally, medulloepitheliomas are considered to be chemo-resistant and radiation resistant. So you can attempt a local resection, but oftentimes enucleation is required for these patients. The one thing that is important to remember is that medulloepithelioma can be associated with the Dicer-1 syndrome, which is characterized by the ovarian Sertoli Leydig cell tumors, pleuropulmonary blastoma, and hamartomas polyps in the small intestine. But also there can be multiple other tumors that can be there in the Dicer-1 syndrome. So whenever you have diagnosed a kid with medulloepithelioma, it's good to do a complete review of systems to make sure they don't have any other involvement. So this is a child that presented with multiple lesions in both eyes with hemorrhages, and this child was actually in a blast crisis of leukemia. So ocular manifestations of leukemia are seen in 30% of children with leukemia. So it's way more than we think it's present. The leukemic manifestations can be either direct or they can be indirect. Direct manifestations include orbital infiltration, optic nerve infiltration, choroidal infiltration, and retinal changes that are called as the rot spots. The indirect manifestations are hemorrhage, branch retinal vein occlusion, and graft versus host disease if the child has been treated with a bone marrow transplantation. This is a child that was a 15-year-old kid that had previously been treated for leukemia and presented with an optic nerve appearance like this, which rapidly progressed. It was treated for a while at an outside facility as an optic neuritis, maybe papilledema, but then even the MRI was not clear-cut. It showed some enhancement. The child was already no light perception, and the lumbar puncture and the bone marrow was all negative, so there was no evidence of leukemic relapse. But with this presentation, it's a very high suspicion. So we actually had to do an optic nerve biopsy, transconjunctival optic nerve biopsy, and it showed the leukemic cells, and the child was successfully treated with radiation. So I kind of want to emphasize that whenever kids have had history of leukemia and they have some atypical presentations, it could be uveitis, it could be optic neuritis, anything, just have a suspicion that it could be a leukemic manifestation. Coming on to this child that presented with a amelanotic elevated lesion in the fundus, and after fine needle aspiration biopsy, it was suggestive of a Burkitt lymphoma. This is post-plaque brachytherapy. The child was treated successfully. And this child had a previous history of lymphoma. So this was a second lymphoma for this child, which could be either from immunosuppression or for chemotherapy. So whenever you're in doubt, you don't know what lesion it is, fine needle aspiration biopsy, though it can give you only a few cells, with a expert cytopathologist, you can oftentimes make a diagnosis. This is a child presented with bilateral presentation with multiple pigmented lesions in the fundus. And this is very characteristic for Gardner's syndrome, which is an autosomal dominant condition in which you have adenomatous polyposis of the large and small intestine, hematomas of the skeleton, and various soft tissue tumors. The risk for intestinal malignancy in adults with Gardner's is close to 100%. So they often need a prophylactic colectomy. The classical eye features is the bear tract that we just saw. The eye features are 78% sensitive and 95% specific. If you do a gene test for Gardner's syndrome, even that is not as specific as the eye feature. So because it's an autosomal dominant condition, it's good to check the entire family for ophthalmic features. Probably this is the only condition where I would look at somebody's fundus and say you need a prophylactic colectomy. But what I want to emphasize is it's a very specific finding for Gardner's syndrome. Coming on to this lesion, it's characteristically called as the mulberry lesion. This is astrocytoma associated with tuberous sclerosis. There are three kinds of astrocytomas that there are three kinds of features that you can see with tuberous sclerosis. One is the elevated one that you see here. And then on the picture on the left, you see a flat astrocytoma. And on this side, you see what's called as a chorioretinal scar. It's kind of like a lacunae. Now, these chorioretinal lacunae have the same diagnostic feature as the astrocytoma. So if you look at the diagnostic criteria for tuberous sclerosis, a flat astrocytoma and a chorioretinal scar like this has a similar point for a diagnosis of tuberous sclerosis. Coming on to these spots in the iris, which are suggestive of lesion nodules and neurofibromatosis. Of course, you're really worried about the optic nerve gliomas, which are seen in 1 to 5%. Radiologically, it is seen in 15% of kids. You can also have plexiform neurofibroma, and you can have a congenital iris ectropion. And oftentimes on the ipsilateral side, you will see glaucoma. Regarding the treatment of optic nerve glioma, of course, there is traditional chemotherapy. You can treat it with radiation. You can also do surgical resection when the eye is a no light perception eye. But a lot has changed with neurofibromatosis treatment with the advent of MEK1 inhibitors. So they have really opened up a new door for treatment of optic nerve gliomas and NF1. This is a lesion with exudation and subretinal fluid, and this is characteristically seen with von Hippel-Lindau disease, which is again an autosomal dominant condition. The retinal lesions usually develop between 10 to 35 years. They're usually multiple lesions, and some of them can be very, very small. So I usually routinely advise fluorescein angiogram because some of these lesions are not seen clinically, but will be picked up on the angiogram. They're quite responsive to treatment with either laser or cryo. If it's a posterior lesion like the one picture that we showed, then you can do a photodynamic therapy. The screening should usually start at the age of 5 for all kids with von Hippel-Lindau syndrome. This is another picture where you see tortuous retinal vessels, and this is suggestive of Wyburn-Mason syndrome. Fortunately, there is no exudation, no leakage. The one important thing to remember is it's usually associated with ipsilateral vascular malformation of the brain orbit and the mandible. So you have to let the patient know that if they're having a dental extraction, that angioma can bleed and can really have a torrential bleed. This is a child that kind of presented with inflammation of the eyelid and was initially treated as an orbital cellulitis, but was actually a rhabdomyosarcoma. And actually 15% of rhabdomyosarcomas actually present as cellulitis. The other common presentation is that they have a trauma and then they have this mass appearing. So you think it's trauma related, but it's actually a rhabdomyosarcoma. It's the most common malignant orbital tumor in childhood. The most common age is 5 to 7 years. Usually do a biopsy followed by chemo and radiation. This is a child that presented with significant redness and sloughing of the conjunctiva. And this is graft versus host disease, which I think is quite underdiagnosed in children. It's seen in 60% of patients with systemic graft-versus-host disease. And we have a flowchart for the management of graft-versus-host disease. Of course, we work with the oncologist for the systemic treatment of GVHD, but the local treatment broadly, we try to decrease the inflammation with either topical steroids, or you can try anakinra, which I don't do often. You try to increase the tear production by increasing the supply with artificial tears or restasis. You can try Xiidra, but oftentimes even on top of the dry eye, sorry, I thought we had some noise disturbance.
Ma'am, actually the time was up, so if you could wind it up.
Okay, sure. So, so this is the for graft-versus-host disease. I'll quickly go through them. So this is a hemangioma, and in Sturge-Weber, you can have a diffuse hemangioma with glaucoma. This is combined hematoma seen in NF2. This is an iris nevus melanoma, and you look at 6 risk factors: age, the hyphema, the inferior clock arc, diffuse configuration, ectropion, and feathery margins to differentiate nevus and melanoma. This is a choroidal nevus, and you use the mnemonic TFSOM-DUH to differentiate nevi from melanoma. This is a choroidal melanoma in a child. Again, very quickly, just for retinoblastoma, I'm going to just go over to the atypical presentations. This is pseudocellulitis. This is retinoblastoma that's presenting as a medulloepithelioma in a 14-year-old, like a ciliary body mass. This is mimicking endophthalmitis with an anterior chamber reaction and hypopion. And this is RB that's presenting similar to FEVR. So in a child, if you have an atypical presentation, always think of retinoblastoma. And of course, raise awareness about leukochoria and early detection of RB. Thank you very much for your attention.